I would like to thank SAGES as well as our chairs, Drs. Kindle and Hilton, for the opportunity to present on the endoscopic management of obesity after gastric bypass. My disclosures are displayed on this slide. None of these will be relevant for the discussion today. The objectives for this session are outlined on this slide. The objective that I will be touching on most is really understanding the endoscopic options for managing recidivism after gastric bypass. Recidivism is difficult to define, and I won't spend time trying to define it. All I will say is that obesity is a chronic disease that is never cured. Now, for the purposes of indications for endoscopic revision, our group has agreed that anybody that has gained weight back greater than 20% from their nadir after bypass, as well as also having a stoma at least greater than 15 millimeters, would be a candidate for endoscopic revision. Now, I know that 15 millimeters sounds narrow, and it is. I don't think any of us often leave the operating room after a primary weight loss procedure with a gastrojejunostomy that is less than 15 millimeters. But I have seen patients who have undergone endoscopic revision and have come back again with weight regain. And when we study them, if they have a stoma that is 15 millimeters or less, I just do not think that they will benefit from any more reduction. And so our indications really are in order to select patients that we feel have the best opportunity to lose weight from any kind of anatomic revision. And I think few would argue that surgical revision carries a higher risk than medical management in the short term. But I also think that most of us would agree that medical management is less effective in most patients. And so I really think that endoscopic options may provide a viable and safe treatment alternative in these patients. Obesity is clearly multifactorial. Only affecting the anatomy is not likely to result in any meaningful weight loss. So we do approach these patients as we do primary weight loss procedures with intensive psychotherapy, intensive dietary counseling. We also manage these patients for weight loss medically for several months prior to any endoscopic revision. I really do think that there are patients who are very motivated to get revised, and it is an opportunity to motivate these patients to get through the system of medical management, both with dietary counseling and psychotherapy. And so we do require at least as much, if not more, of those non-surgical, non-procedural aspects of weight loss prior to any endoscopic therapy. Now, we looked at patients who came to us for endoscopic revision, and there were several patients who did not obtain insurance clearance for the procedure, and so we compared those patients over the course of 2 years to those who did get insurance approval for the procedure. And as you can see here, the solid black line, these are patients with the percentages of those that were able to follow up with us up to 2 years. There was a significant difference in body mass index and weight loss in those who did obtain a revision versus those who just went on with dietary and just medical management of their weight regain. So I do believe that endoscopic revision, as you'll see, the numbers are not dramatic, but we do arrest weight gain in almost all of the patients, and we do get some modest weight loss. So I do think it is worth considering in these patients. Now, there have been many endoscopic options over the years. The options that you see on the left side, like EndoStitch and StomaFix, the Rose procedure, those really have either completely disappeared or are rarely used these days. There are some now that are recommending sclerotherapy procedures alone, such as just argon plasma coagulation of the mucosa around the stoma or endoscopic mucosal resection. And there are some modest results again from that, but not a lot of long-term follow-up. I personally believe that the hybrid of plication and sclerotherapy is the best current option for patients who gain considerable weight back after bypass. So we use the Apollo overstitch, which is a plication device endoscopically, and the procedure has a couple different names that you would see in the literature, like transoral outlet reduction, which is also known as endoscopic gastrojunal revision. But coupled with that, we will perform sclerotherapy with argon plasma coagulation, and I'll also discuss a newer form of sclerotherapy, which would be endoscopic submucosal dissection of the mucosa around the stoma at the time of the plication. But again, hybrid plication and sclerotherapy are superior at the moment to any other endoscopic approaches. So this is an image of the endoscopic suturing device. And basically it's just used simply to reduce the diameter of the gastrojunal anastomosis. And this should be coupled, in my opinion, with mucosal ablation with either APC or endoscopic resection. Here you can see a picture of a stoma and then mucosal ablation on the top right, followed then by interrupted suturing. I'm going to get to the suture patterns a little bit later in the talk, but when we started, we performed interrupted sutures that has now evolved to purse string suture placement, and I will touch on that again later. Now again, we use permanent sutures for this, and here's a video of the procedure itself. There is the gastrojunal anastomosis. Here we're using argon plasma coagulation to coagulate and the mucosa around the stoma. We then will use, again, permanent sutures and grasp both sides of the stoma, in this case, with an interrupted suture pattern, and then cinch it closed. Our goal is to get the stoma diameter somewhere between 4 and 10 millimeters. Any less than 4 millimeters, you can imagine, would result in obstruction, and as you'll see later, anything more than 10 millimeters probably won't achieve as much weight loss as under 10. So in our first 25 patients, we were able to reduce the diameter of the stoma almost 80%, and we had no complications and a reasonable procedure length. The endoscopy lab procedure length is about 43 minutes. The OR procedure length is a little bit confusing in that there were some times that a concomitant procedure was done. But we did find that the percent reduction of the stoma was significantly associated with weight loss over time. And as I said earlier, the weight loss outcomes are modest. We just published our 5-year data. We saw about a 7% excess body weight loss at 5 years. We did get up to close to 20% at 6 months. And we do see a considerable drop-off in patient follow-up. And we just don't know if that biased population happens to be those that maybe didn't lose their goal and are following up because they're hoping for more help from us, with perhaps the people doing well kind of disappearing from our practice. But in any case, you know, the results in those that followed up with us is modest. However, if you look at the patients when they come out for a consultation, they are experiencing significant weight gain, about an average of 10 years from the nadir, and we are arresting that weight loss in just about everybody, seeing a decrease that does sustain itself even out to 5 years. And this is, again, why I do think there is utility in doing a procedure that results in very minimal complications, really no effect negatively on quality of life, and potentially an increase in quality of life based on even some modest gains in weight loss. Now, Chris Thompson and his group at Brigham and Women's has also a long and large experience, and they've been able somehow to get a bit better follow-up than our group. And if you look out to 5 years, they again are having pretty good results with total body weight loss approaching 10% at 5 years. And the patients with greater than 5% total body weight loss um, is significant as well, as you can see here. So again, the data looks promising. 5 years, in my mind, you're getting out, far enough where it does seem that this has somewhat of a uh, long-term effect on the stoma. If you look at what is the best predictor for weight loss after this procedure, really it's stoma reduction. Patients who have at least an 85% reduction in stoma diameter sustain superior weight loss at 6 months, 1 year, and 2 years after revision compared to those that have less than 85% reduction. And so out of all the predictors, this one is the one that persists. So really getting that stoma down as much as possible, but again, I would say no less than 4 millimeters so that you avoid obstruction, is what your goal should be when doing this procedure. Now, suture patterns is interesting. When we first started, simple interrupted sutures were what I thought would be best, because if one suture broke, there would still be others that would hopefully be contributing. But we decided to take this to the lab and decide, and we created several gastrojunal anastomoses on ex vivo models, and we then performed several suture patterns and compared them. And what we found was that the more bites that you take, the better. And so out of all the suture patterns, that hairpin pattern actually was the one that was able to withstand air and water pressure the most. Purse string suture pattern was next. Now we took this data then to the clinical arena, but what we found, however, was that the hairpin suture pattern was a bit difficult to do technically. And so for the last several years, we have really relied on a purse string approach. And what we have found actually is that if you compare the purse string approach to an interrupted approach, you actually do have higher weight loss in those patients. So at the moment, we recommend that an endoscopic approach be considered after weight regain, after gastric bypass. However, this would be after intensive psychotherapy and dietary counseling. And then in terms of the technical aspects of the procedure, a goal would be to perform a purse string approach and with sclerotherapy, narrowing the stoma to somewhere between 4 and 10 millimeters. Again, Chris Thompson's group looked at whether or not the type of sclerotherapy used, the technique used, would actually have an effect on weight loss. So in the top row, you see an endoscopic submucosal dissection approach where the mucosa around the stoma is actually resected using an ESD technique of lifting and resecting versus the standard argon plasma coagulation as you see in the bottom row. And they did find that the ESD group experienced a higher weight loss, 12% versus 7.5% total weight loss at 12 months. And on regression analysis found that ESD remained a significant predictor of total body weight loss at 12 months after controlling for several other factors. So again, this is relatively new, but another consideration. I think that the theoretical thought with the sclerotherapy is that mucosa to mucosa is not likely to scar, and the hope would be that getting the submucosa to adhere to each other may affect the long term or the duration of effect that we see with weight loss. And whether you get that through argon plasma coagulation or ESD, their group would suggest that ESD is better. So in conclusion, I think endoscopic management is certainly superior to medical management for patients gaining weight after gastric bypass. I think it's clear that right now the hybrid of plication as well as sclerotherapy is a safe and feasible option that arrests weight gain in most of these patients. And the goal should be for at least an 85% reduction in the stoma diameter. It does seem that a purse string suture pattern is superior, and in the future we may see more of an aggressive resection of that mucosa using ESD. And I also think that the addition of pharmaceuticals is something that may help in, again, these patients that have a significant lifelong problem. So I want to thank all of the SAGES members for the opportunity to speak on this topic, and please feel free to contact me if you have any specific questions